The study being presented is the effects of exposure therapy on anxiety for a child with autism. The study was conducted by Brittany Bergstrom, Alexandra Messina, and Angela Schuckman. Abstract. Many children with autism suffer from sensory disturbance and hypersensitivity to sound that results in an increase in anxiety. Sensitivity to common stimuli causes additional stress to individuals and their families and can increase the risk of isolation of that individual. The purpose of the current study is to evaluate the effectiveness of exposure therapy using sounds on an iPad to reduce anxiety in a child diagnosed with autism spectrum disorder. The effects of this intervention were evaluated using a criterion-changing design. Results of the current study suggest that exposure therapy is effective in reducing anxiety with a child with autism. Autism spectrum disorders is characterized in the DSM-IV by cognitive, social, and affective impairments and evidence of restrictive patterns of behavior and interests, according to the American Psychiatric Association. Symptoms of ASD can range from mild to severe, and sensory disturbances are common. Anxiety in children. In the book, Children's Phobias, A Behavioral Perspective, anxiety is defined as an aversive or unpleasant emotional state involving subjective apprehension and physiological arousal of a diffuse nature. It is estimated that 5% of children display an anxiety disorder. Common forms include over-anxious disorder, separation anxiety, generalized anxiety disorder, and phobias. Anxiety and autism spectrum disorders. Diagnosing anxiety disorders has proven to be somewhat difficult. Anxiety and autism share similar symptoms. Hypersensitivity to sound is common in children with autism. A study conducted by Rimland and Edelson in 1995, based on parent reports, suggests that 40% of children with autism show some symptoms of auditory hypersensitivity. In children that experience hypersensitivity to sound, reactions can result in challenging behaviors such as screaming, crying, eloping, covering ears, aggression, or self-interest behavior. These behaviors can also increase stress for family members. Exposure therapy. During exposure therapy, an offending stimulus is gradually reintroduced to an individual. The intensity or ranges of the stimuli are gradually increased across sessions until habituation to the stimulus occurs. Exposure therapy is a type of cognitive behavioral therapy. It encourages confrontation of feared or offending stimuli. It is underused, and a small percentage of individuals with fear and anxiety are treated with exposure therapy. Exposure therapy can target internal and external stimuli. Exposure therapy research. Exposure therapy has been proven to be effective in treatment for a range of anxiety disorders. For treatment of simple phobias, Marks, in a study in 1979, suggests that exposure therapy relieves the symptoms after the individual undergoes approximately 8 sessions of treatment. Types of exposure therapy. In vivo, confrontation of fear in the real world with objects or real scenarios. Imaginal exposure. Individual is asked to imagine their fear and give verbal descriptions. Virtual reality exposure. Using technology, individuals are placed in situations that appear to be real. Previous research. Exposure therapy and response prevention indicated positive effects for patients with OCD compared to treatment with drugs or a combination of both. There's evidence that exposure-based therapy has proven to be effective in treating symptoms of PTSD. In one previous study cited by Sakardolsky and colleagues results indicated positive effects of combining exposure response prevention with parent management training for children with OCD engaging in disruptive behavior. Another study by Jameson and Oat in 1982 indicates that in vivo exposure therapy was proven effective for those suffering from the phobia agoraphobia. Research question. The current study asks, what effects does exposure therapy have on reducing anxiety in children with autism spectrum disorder? Our study focuses on anxiety in children diagnosed with autism. Much of the past research participants have included undergraduate volunteers. Our study utilizes effective reinforcement, single subject design, effects of exposure therapy alone, effects of exposure therapy on anxiety, the effects of intervention evaluated with a criterion-changing design. Participant. The participant of the study was a 13-year-old boy diagnosed with autism spectrum disorder in accordance with DCSM. Kyle attends a communication development program through a co-op that provides services for a school district. He is currently in a self-contained classroom within a public school and attends art, music, gym, and lunch and recess with regular education peers. Kyle's anxiety has a severe impact on his daily living and academic skills. His anxiety stems from what has been hypothesized as uncontrollable sounds, such as pencil sharpeners, fire trucks, ambulances, iPad timers, school bells, telephone rings, etc. His anxiety has caused him to wear headphones 17 hours a day apart from his school day. He has also begun to exhibit behavior issues, for example, screaming and swearing at students and staff, throwing objects, running out of the building, and severe outbursts. Kyle is averaging 167 outbursts per day over the 4 weeks prior to therapy. Mom has requested assistance in helping Kyle to cope with his anxiety. They have recently moved into an apartment building and are at risk for moving due to Kyle's outbursts. Setting and stimulus materials. The exposure therapy sessions were conducted in a quiet, empty classroom. Sessions varied depending on what subphase of exposure therapy Kyle was completing. Times of exposure therapy were written on his schedule per his choice. Within the classroom, there was a table, 2 chairs, iPad, timer, the Hullabaloo game, which was the reward for completing the designated time. There was also a data chart to take the data on the completion of each subphase of the exposure therapy criteria to be met. Observers tallied any unacceptable behavior during the session that would cause it to be terminated. Dependent variable. Predetermined criteria varied per subphase for listening to and tolerating the iPad sounds, typically broke down into a certain number of minutes per session over a chosen number of sessions per day. Tolerating the iPad sounds was defined as sitting quietly, no screaming, no swearing, and hands placed on the desk or on his lap, not on his ears. He was allowed to make a white noise if he chose to during the time session. If Kyle swore at any point in the session, he automatically lost his Hullabaloo game, but the time session continued. Intra-observer agreement. 2 observers collected data during 75% of all sessions. During the designated time for each phase, each observer tallied the number of times Kyle exhibited any behavior that would cause the session to be terminated. Example, plugging his ears, swearing, not sitting with his hands quietly on the desk, yelling phrases at the staff. Intra-observer agreement was calculated by adding the number of tallied prompts, dividing the smaller number of prompts by the larger number of prompts, and multiplying them by 100. Intra-observer reliability percentages were noted for each of the following stages. Baseline phase, 92%, and the intervention phase, 94%. The overall average of intra-observer agreement was 93%. Procedural integrity questionnaire. Procedural integrity questionnaire was given to teachers and observers. Treatment integrity of the independent variable was recorded on the datasheet by the teacher and observers during 33% of the sessions where the intervention was applied. Integrity was 100% throughout the study. Design. The effects of this intervention was evaluated using a criterion changing design, typically used for a single target behavior to evaluate the effects of treatment that is applied gradually. Once baseline is taken, it is followed by the treatment phases. Once each phase is stabilized, that particular treatment phase serves as the baseline for increased criterion for the next phase. It is a variation of a multiple baseline design. Baseline data. Prior to the baseline, Kyle was exhibiting an increase in behaviors and a significant decrease in his ability to complete daily living tasks and academic tasks. As observed, his anxiety has shown a significant increase since the end of the 2014-2015 school year. Baseline data was taken for the 4 weeks prior to the intervention being implemented. Kyle was averaging 167 outbursts per day for a variety of anxiety-building reasons. He would often begin to scream if another student chose the iPad as a reward, or if he thought that a student may make that choice. Kyle was unable to tolerate 5 seconds of the iPad sounds being played during baseline phase. During that 5 seconds, Kyle required 4 prompts to exhibit the desired behavior. Those included various games being played by other students, timer sounds, and specific music from a variety of apps from the iPad. Staff determined that the uncontrollable sounds Kyle was struggling with the iPad sounds were those that they felt they could most control, an attempt to provide coping skills in hopes Kyle may acquire the ability to generalize his learning coping to the other sounds that cause his anxiety, therefore increasing his tolerance and ability to function independently. Intervention procedure. Each subphase started when Kyle identified the time of day that the iPad sounds would occur. At the beginning of each day, depending on the subphase, Kyle wrote on his schedule when he wanted the session to be. This provided him with control over the situation. Kyle and the observers would go into the quiet classroom and prepare for the iPad sound session. They sat at a table across from each other. The timer was set to the desired time. Timer was started, and the observer played the iPad sounds for the duration of the session time. Session continued regardless of whether Kyle exhibited the desired behavior or not. Once the session was completed and Kyle had exhibited the desired behavior throughout the session entirely, he was able to play the Hubaloo game for 5 minutes. Intervention procedure continued. Meeting the criterion for each subphase was determined by Kyle exhibiting the desired behavior for the entire time session, with no more than 1 prompt per minute for 3 consecutive sessions. Once met, the criterion was then changed and subphase sessions started again. Subphase criterion were 1 minute, 2 minutes, 3 minutes, 4 minutes, 2 minutes again, which was the minute reversal included for experimental control, and then 5 minutes. The criterion was considered met if it met that minute mark or within plus 15 seconds. Social validity. Treatment questionnaire was given to parents and teachers. It was a 7-point Likert scale, 7 questions. The results of the TARFR calculated average response. 1. Clearness of understanding was 0.64. 2. Acceptance of intervention was 0.67. 3. Reasonable procedures was 0.65. 4. Willingness to carry out plan was 0.64. 5. How costly was 0.20. 6. Level of distress was 0.32. 7. Liked the procedures was 0.66. The results indicated that the parents and the teachers viewed the procedures as appropriate and acceptable. On this slide is a copy of the treatment acceptability rating form. It was modified to fit our study and assess the acceptability of the intervention, cost effectiveness, and willingness to carry out the procedures. Results. On this slide, there is a picture of our changing criterion design graph for the duration of exposure to the stimuli, the iPad sounds. To recap, the intervention subphase criterion were the first was 1 minute, 2 minutes, 3 minutes was the third one, 4 minutes. There was a 2-minute mini reversal, and the last subphase was 5 minutes. To recap on the previous slides, Kyle was only allowed 1 prompt per minute. The average number of prompts in each subphase was 1 for 1 minute, 1.5 for 2 minutes, 2.8 prompts for 3 minutes, 3.7 prompts for 4 minutes, 1 prompt for the 2-minute mini reversal, and then 3.5 prompts for the 5-minute subsessions. The baseline data shows that there were near 0 levels of tolerance for Kyle being exposed to the iPad sounds. During subphases 1, 2, and 3, Kyle dropped slightly below the desired criterion. He was only within 5 seconds of making it to the desired criterion time. The sessions were carried out until the data was stable, and it was either at or slightly above the criterion for at least 3 sessions. The findings of our study were parallel to those of other exposure therapy findings. Our exposure therapy had a positive effect on increasing the tolerance for the iPad sounds. As discussed in the introduction, Marks, a study done in 1979, suggests that exposure therapy relieves the symptoms after an individual undergoes approximately 8 sessions of treatment. Our results from our graph showed that during subphase 3 and 4, both of these subphases were 8 sessions long and showed tolerance of exposure to stimuli. Limitations and threats to validity. There were no other interventions used to compare the results or differences among alternative therapies such as psychodynamic therapy or cognitive reconstruction. There was no physiological measurement, unknown correlation between the number of prompts given in each session and the duration of exposure to the iPad sounds. Further research that may want to be conducted, study with exposure to other types of sounds. More research needs to be conducted in order to compare results of this study to studies similar, and studies conducted on different classification of participants, and studies conducted for generalization of exposure therapy.